So my topic is a palliative approach to pediatric pain. And I'm going to hit on some themes that were talked about yesterday, some themes that will be talked about more during this week. But if people aren't aware, most people here, I think, know what palliative care is. But the term to palliate actually means to reduce suffering. So I aim to do that a lot. And treating pain is a big part of that. So I have no financial or industry relationships to disclose, for better or worse. And our objectives today are to describe different ways to conceptualize the experience of pain, to discuss setting appropriate goals and expectations for pain management, and to review modalities of pain management and their use in the formulation of a tailored and really individualized pain treatment plan. So this might seem like a basic question and a little bit addressed for those who were at the lecture yesterday, but I actually want to open this up if anyone has an idea of how to actually define pain. And I'm going to be asking you guys questions today, so. Oh, come on. I know there's at least one person who's rotated with me who might have an answer to this. It actually is difficult to define, though, because you can think of pain as the glutamine release that leads to this inflammatory soup and then release of substance P activating A delta and C fibers and then going up to your cortex. But that doesn't really seem to capture what pain is, at least not to me. And people talk, there was a movement a number of years ago to make pain the fifth vital sign. But it would be a weird vital sign if you really think of it that way, because all of our other vital signs you can count. You can put a number to it. You can use a monitor and say, you know, their respiratory rate is this, their pulse is this, their blood pressure is this. But then you say, and what's your pain? So it seems a lot more fuzzy. We try to be objective about it and put numbers to it. But even our efforts to label it more objectively with those numbers, it's still looking at a patient and saying, you know, are they kind of relaxed or are they kind of not? Don't get me wrong, there is a lot of utility to assigning numbers and being able to say, sort of on this scale, is it on the bad end or is it on the not so bad end? But it still is a lot more subjective. So people have thought a lot about this in trying to define pain. And a definition that I think is pretty good from the International Association of the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. That's a little bit wordy. The way I think of pain really boils down to pain is a perception. It's a combination of the sensory inputs that you're getting, but that doesn't explain it all. It's an emergent phenomenon. And something that is kind of a real-world experience for me that drives this home is when thinking about what for me would be as kind of a prototypical patient that I'm asked to treat their pain. So a bone marrow transplant patient who has mucositis, has oral pain, abdominal pain, rectal pain, you'd expect them to be having pain and to be reporting pain. But how do you think that patient is going to report pain? What kind of numbers would they give if they've been hospitalized for over a month, and now they don't have any visitors anymore, and they are just completely isolated in their room. How do you expect a bone marrow transplant patient with mucositis to be reporting their pain if they think their cancer is a punishment from God? Or if they have anxiety, or if they have depression, or if they're a teenager who is saying that they think life is meaningless, and their cancer is meaningless. All of these patients will tend to report higher numbers of pain when they're asked. And that isn't because they're lying. It's because that's their experience. And this gets to the idea of total pain, which is really a foundational concept in the field of palliative care. The term was coined by Dame Cicely Sanders, who actually founded the first hospice and really started palliative care. And it boils down to the idea that the perception of pain is impacted by all forms of suffering in a person's life, not just physical, but also emotional, spiritual, social, existential. And throwing more opioids at these patients when they are having these forms of suffering is not going to help. So I can't fix all forms of suffering, but we can at least attend to it and do what we can to try to ease those forms of suffering too, in order to treat pain. So I'm going to name a couple of principles for palliating pediatric pain, which is really Noam's approach to treating pain. The first is treating physical aspects of pain is only part of the solution. So with all that said, let's talk about treating physical aspects of pain. What tools do we have in our toolbox? What meds do you guys prescribe? Basic things. Tylenol, NSAIDs, awesome. What else? Opioids, okay. Anything else? Those are yeah. I would say there's some overlap there, but yeah. SNRIs, awesome. So we are now getting past just the nociceptive types of pain treatments, but also into the neuropathic. So the nociceptive, the big ones we think of are Tylenol, NSAIDs, opioids. And for neuropathic, any other? Gabapentin, yay. You guys know me. And so gabapentinoids, so not just gabapentin, but also pregabalin. SNRIs, I don't tend to use them as much because of side effects, but tricyclic antidepressants are really the classic treatment for neuropathic pain. Anything else that maybe you've seen me use or just is a little bit more out of the box? Awesome, yes. So while I've separated this slide into two sides of nociceptive and neuropathic, there are a couple of things that have good coverage in both areas, or at least some coverage in both areas. So the alpha-2 adrenergic agonists like clonidine or dexmedetomidine, Precedex being like the IV version. NMDA receptor antagonists are primarily used for nociceptive pain, but there is some evidence for neuropathic coverage. And cannabinoids, not the first line I would use for pain, but there is certainly some evidence both for nociceptive and neuropathic. What's interesting about the NMDA receptor antagonists, so the prototypical one for that is ketamine, which is not something we use day to day outside of the ICUs. But methadone, which I at least use a fair amount, is both a opioid and an NMDA receptor antagonist. So when we're looking to get some of those properties, that's another way to get that. And then there are things, this is kind of my toolbox. There are things beyond that that I don't use as often. So glucocorticoids can be used specifically for like bone pain. Sodium channel blockers like lidocaine and other anti-epileptics. Oxcarb is kind of the classic there, but there are many that have been used with varying degrees of evidence. And that's completely ignoring a whole nother subset, which I think of as more local agents. These are the ones to treat a specific problem that you can localize. So things like BMX for someone who's having oral pain from mucositis, Carafate for GI pain, Pyridium for urinary colic, heat, cold, we shouldn't forget about those basic things. We do have a topical NSAID, diclofenac, which can be really useful if you have just one joint that's really painful and you want to avoid the systemic side effects of NSAIDs. There's also, you can make a morphine gel, which is kind of a hospice trick that they use a lot for any wounds or sores, and avoiding the systemic side effects from opioids. We also have lidocaine patches, topical capsaicin, which help for neuropathic pain. And then I can't do this, but I can phone my friendly neighborhood anesthesiologist for blocks, regional anesthesia, epidurals, things of that nature can be a really great tool, and also keep people awake instead of completely sedating them when they're having significant types of pain. So my next principle for palliating pediatric pain is to be specific about the pain you're treating, to try to categorize it, at least between nociceptive, neuropathic, to be specific if there is something localized, treat it localized and avoid the systemic side effects because all of our meds have side effects. So even though I just told you to be specific and treat things localized, it's also definitely true that combining analgesics works together better than any analgesic on its own. The whole is really greater than the sum of the parts, and this middle class, like I said, does have some coverage both in nociceptive and neuropathic. The neuropathic agents, I wouldn't use them on their own for nociceptive pain, but they can be used as adjuvants and can be really helpful. Going in the other direction, unfortunately, using Tylenol for neuropathic pain, that does not work. So my next principle is to use multimodal analgesia for synergistic effects. All right, so now that I've talked about all the other tools in the toolbox, I'm going to talk about opioids because that is a big part of treating pain and is often the reason that I'm called. And it's, I think, important to have a bit more familiarity, and some of the stuff will probably be review. They come in many flavors. There are differences, but the big picture, the differences are relatively minor. And you can convert between them to achieve what's thought of as an equianalgesic dose, that if you know the appropriate ratios, which I believe there's a lecture on Thursday about drug math, we'll talk in more depth about this, you can achieve the same amount of analgesia. Is that an unusual concept? Okay, that's good. So I now want to ask you, what's the difference between giving someone oral oxycodone, probably the most common opioid we use, and IV morphine? If you can achieve the same amount of analgesia if you just know the ratios. Not that big a difference, right? The difference, it's not that IV morphine is stronger than oral oxy, or really any IV opioid is stronger than any oral opioid, as long as you're not using one of the weak opioids, which I would just recommend you not use in general. The difference is that you give something IV, they feel it right away. There's a much more rapid onset. You achieve that peak sooner, but it also doesn't last so long. You give something enterally, it takes a lot longer to get to that peak, but the duration is more sustained as well. And so if you think back to pain being a perception, kids might be asking for IV opioids because they're in a lot of pain and they feel like they need something right now. And that may or may not be appropriate, but that is probably why they feel like the IV medicine is stronger. So I said we're not going to talk a lot about drug math, but just so that you see a relatively simple table of converting between, there are other tables. This also ignores the concept of incomplete cross-tolerance, which I'm also going to ignore today because I know you have another lecture on Thursday. But in brief, it's just the idea that when you're switching classes of opioids and someone is tolerant to one, they will be less tolerant to the next. So the biggest problem with opioids, at least from my perspective, is side effects. So what side effects do you guys know? Yes. Very common, should be expected anytime you start someone on an opioid. Anything else? Yes, that's what we always worry about. Not very common, but it's something you should worry about. Anything else? So itching can be pretty common. Somnolence is something that can happen. Then after people start getting sleepy, they start getting altered, confused. And it's usually in this order that someone starts getting sleepy, they start getting confused and altered, and only then would you get to a point of respiratory depression. It doesn't have to go in a nice linear fashion like that, but if you're increasing doses appropriately, you should start to get to the somnolence, the altered mentation, before you ever get to respiratory depression. And if you start seeing those signs and back off, you should never actually get to the point of respiratory depression. There are times that there are people who are really sensitive, who don't go in a nice order like that, but in general, it's important to know that. Other side effects, which we think about less commonly, are things like nausea, urinary retention. You can have delirium, myoclonus, especially from morphine, especially if your kidneys aren't working so well and you build up a metabolite, which doesn't give you analgesia but does cause side effects. And hyperalgesia is not something that I've seen frequently, but it is something that can certainly happen as someone has been on opioids for a long time. There's some evidence that you start to overexpress the NMDA receptor, which is a pain receptor, and maybe that can hint to us what we can do for those patients by maybe using an NMDA receptor antagonist, like ketamine or methadone. So that is something to be aware of as well. So whenever I'm talking about opioids and talking about starting a patient on opioids, I think it's very important to manage our expectations of treatment. In palliative care, but really I think for everyone, goals of treatment should be aligned with overall goals of care. And generally, our goal is to make pain tolerable so that the patient can function. It is not a reasonable expectation for pain to be brought to zero. And telling patients and families that these are our goals with using pain medications up front can save a lot of heartache further down the road. Now, I did say generally because I do palliative care, and there are times where the focus goes from life prolongation to a focus that's completely on comfort and relief of suffering. And there are times, although it's not common, that I would continue escalating opioids up into the point of really putting someone to sleep so that they can be sleeping and comfortable rather than awake and in pain. But that is a very rare situation and not something I would expect people outside of palliative care to ever be doing. So do tell your patients that we will not get your pain to zero. We are not trying to get your pain to zero. We are trying to get it to be tolerable so that you can function. It's also, I think, really important to talk to patients up front about these things that they are worried about. If they ever listen to the news or just live life in Ohio, they are probably aware of the idea of addiction from opioids and how big a problem that is. Explaining to patients up front the different concepts of tolerance, dependence, and addiction. Is anyone brave enough to offer a definition for tolerance?
You need more pain medications after a certain period of time. So like you may, 2 milligrams of morphine may control your pain for a certain amount of time, but then after that you'll need to have 4 to be able to actually adequately treat your pain to the same point of the 2.
Awesome. So tolerance just means that you need increasing doses to achieve the same effect, that your receptors become tolerant. Dependence is different than that, and since I showed it to you for a second, I'll just show you this. Dependence means that you will have withdrawal, you will have symptoms if we just abruptly stop the medication. That's not the same thing as addiction. Dependence is a physical phenomenon. Addiction is really a psychological condition. It's fed into by dependence, and especially when dependence isn't well managed and people go through with addiction and go through withdrawal and they come to believe that they need the drug, but it's not the same thing. And when people are addicted, they have cravings, they act and do things that they know aren't in their self-interest to obtain the drug. It is a difficult problem to manage. Part of managing, though, is talking about this up front, having the patient understand that even if they have withdrawal symptoms, that doesn't mean that they will be addicted for life. And that can really go a long way. So our next principle for palliating pediatric pain is to set expectations consistent with goals of care before starting treatment. So now we get to actual dosing of opioids. So we just talked about tolerance. It's an expected phenomenon when someone is on opioids for a while. Opioids, unlike a lot of our other meds, don't have a ceiling dose. We're limited by side effects, but a lot of the side effects you get tolerant to with time. Constipation, notably, you don't. Opioids should be started at weight-based doses, but then need to be titrated either up or down based on how the patient does and the need that they demonstrate. So our next principle is to titrate opioids to clinical effect. It's not like Tylenol, which is 15 per kilo every time you use it. It's a moving target. So how do we time doses? Anyone really love treating diabetes and want to explain this? Because this slide I took completely from somewhere else, from dosing insulin. All right. I don't really love diabetes either, but what this slide shows is if you know someone has a base level of blood sugar that you need to control all the time. So if you're treating diabetes, you give them long-acting insulin, You have some coverage for their blood sugar all the time. And then when things happen to increase your blood sugar, like eating, you don't say, well, they've got their long-acting insulin, so they don't need something. No. You give them something short-acting to cover the spikes. We also don't really like only giving people short-acting insulin, only to give them something for spikes and not have anything long-acting, because then when you sleep at night, your blood sugar is not going to be under good control, and you'll wake up and your numbers will be all wonky. So maybe that's a more familiar concept than treating pain, but it's very analogous to treating pain, because you want someone to have baseline pain control, baseline analgesia, and the ability to get something more when their pain number spikes. So going back to my prototypical patient with mucositis, I expect that patient to have pain all the time. I also expect that if they try to eat something, that pain is going to spike because they're going to agitate the parts of their body that are inflamed. So I would make sure that they have some pain medicine that's scheduled and then something else PRN. And only dosing something PRN when you expect someone to have pain is inappropriate. To get a med that's PRN, you first have to be in enough pain to ask for it. Then the nurse has to go draw it up, has to go administer it, and it takes a lot of time. Pain escalates kind of the same way blood sugars escalate when you ignore them, and it's much easier to keep things at a simmer than to turn your back to the simmer in the kitchen and it becomes a kitchen fire. So our next principle for palliating pediatric pain is to time doses concordant with the mechanism of pain. So if someone has leg pain when they're up and walking around but doesn't when they're in bed, it's okay for them not to be on scheduled things, but just take something before you get out of bed. But in most cases, you want something scheduled and PRN. All right, so I've talked for a while. Let's do some actual cases to make things more concrete. Jake is a 15-month-old who had severe neurologic impairment after being the victim of non-accidental trauma as an infant. Sorry, it says she, but he is G-tube dependent, but has not been tolerating his feeds. As soon as feeds are initiated, shows signs of pain, back arching, moaning, teeth grinding, tachycardia. Attempts at changing formula, changing rate, adding a PPI have not yielded improvement. Any idea what might be going on with Jake? Has anyone seen anything like this before? Yeah? Because there are lots of reasons people might not tolerate their feeds. It's harder in a nonverbal person to get a story, but there are some clues here to me of what might be going on. One is that they seem to be in pain. Another is that the pain seems to start as soon as tube feeds are started, which is kind of unusual. Most of the time when there's feeding intolerance, you start out okay, but then the pressure gets to be too high, the volume gets to be too high, maybe you reflux, and that's when they have a lot of pain. But what this patient's displaying is something that's called visceral hyperalgesia, which is an unusual syndrome, but a syndrome that happens to our patients with neurologic impairments. And I kind of think of it akin to allodynia of the gut. So a sensation that should not normally be perceived as painful. the gut starts perceiving as painful. And that is a neuropathic pain type syndrome. So how would I treat, or how would you treat neuropathic pain? Yeah, gabapentin, maybe some clonidine as well. In this age group, I am hesitant to use SNRIs or TCAs, but those are options as well. And the patient, the names and faces have been changed to protect the innocent. The patient this is based on did do well with starting these agents. But then the family wanted to wean them off, and probably the problem got better. I have had patients who they outgrow this, and they were convinced that doing, short bolus feeds helped. We were able to wean off meds and did quite well. All right, so let's get to opioids. Samantha's an 8-year-old who weighs 30 kilos, has a history of OI, has chronic fractures and bone pain at baseline. So she's on long-acting morphine, 60 milligrams twice a day, with an additional 15 milligrams of short-acting morphine as needed. She's admitted with gastroenteritis, so she hasn't been able to tolerate PO, and she says her pain is 9 out of 10. What would you want to do for her? So, her all over bone pain. So you definitely could use a PCA. The main thing is she can't take her oral morphine, give her IV, right? So dust off your calculators. 3 milligrams of oral morphine should be equianalgesic to 1 milligram of IV morphine. Here's my first question. Is giving her 0.1 per kilo of morphine an appropriate dose? So it would be if she was opioid naive, but she's not opioid naive. She takes 120 milligrams of oral morphine. So divide that by 3, and you get 40. Come on. Tried to make the math easy for you. But that's actually not all she takes, because in a normal day she takes 4 PRN doses. So she actually takes 180 milligrams of oral morphine in an average day. And divide that by 3. That's 60 milligrams of IV morphine in an average day that she takes. So if nothing else is going on and she just can't eat, you would expect her to need 60 milligrams of IV morphine today, right? Morphine lasts about 4 hours. So if you divide that out to 6 doses in a day, I tried to make the math easy, 10 milligrams of IV morphine scheduled would be a starting dose for this patient. Does that seem like a lot? Yes, it is a lot. And I played with the numbers to make the math easy, but this is based on a real case who was taking a lot of oral morphine. So would you only want to give her 10 milligrams Q4 hours scheduled? Or would you also want her to have a PRN? Yep. Okay. Because even if you expect someone to have baseline pain, you need to have something available for when their pain increases. So I would start this patient on something like 10 milligrams IV morphine every 4 hours scheduled with, and this is more art than science, but I typically do half that dose at half the interval for my PRN, with an additional 5 milligrams Q2 hours. So yes, that is a lot, but this is a patient who has been on opioids their entire life and is tolerant. and has constant pain that should be addressed. So in this example, she has been, throwing up, might have some additional rib fractures to her baseline pain. So she's actually been using a fair amount of her PRN doses, got 6 in the last day, and at this point, people are saying this is ridiculous. Noam, can you start her on a PCA? And I would say sure, but since we're talking about this to you guys now, the way I typically dose PCAs, there are weight-based starting doses to PCAs, which you should use for people who are opioid naive. For a patient like this, starting at those weight-based doses, again, doesn't make sense. But I have a very clear indication of what her pain needs should be at this point. A PCA is great because we can control the basal, the amount that's going in all the time. We can control the demand doses, the amount that they get when they feel like they need something extra. And the interval between, we can see exactly how much they're needing and make more fine dose adjustments. So I typically start my PCAs for people that are on opioids by saying, okay, you've demonstrated in the last day, or extrapolating to the last day if I don't have a full day's worth of data, how much you need. I'll give you 2/3 of that in your basal, assuming that you'll probably get the other third by pushing the button. But maybe I'm wrong. Maybe you need a lot more and you push the button a lot more. Maybe you actually need less. There's some room for you to get less if you're not pushing the button. And then we can make adjustments like that. So doing the math for you, that comes out to a PCA with a basal of 2.5 milligrams an hour, and starting the demand the same way at 2.5 milligrams. Make sense? Yeah. So it's not magic. Math is actually helpful. So our next patient is Lisa, who's a 17-year-old with high-risk osteosarcoma to her left humerus. Some of you might know the patient this is based on. She complains of 8 out of 10 pain at her tumor site, diffuse muscle tension, and burning, tingling pain distal to her tumor site. She has been prescribed oxycodone 10 milligrams Q6 PRN, but has actually been taking them every 4 hours. And says she has moderate relief at this. So how would you guys want to approach this? Do we think her pain is well controlled right now?
No.
Okay.
Looks like she has like a neuropathic component.
Definitely, yes. And the easy part, at least for me, is her oxycodone. She's getting essentially 10 milligrams Q4, or if we wanted to make her life easier, 15 milligrams Q6. So we could start there while also doing things to adjust her neuropathic pain. And what if I told you that she also has anxiety with panic attacks? Maybe our go-to med wouldn't necessarily be starting with gabapentin like I want to do, but an SNRI where you can address those as well. So the SNRIs with the best evidence base for neuropathic pain are duloxetine, Cymbalta, and venlafaxine, Effexor. The Effexor does have some evidence that it's maybe better for people with panic attacks. So I started her on that in addition to gabapentin and oxycodone of 15 eventually gabapentin and oxycodone of 15 milligrams Q6. Anything else that's maybe kind of nice about the kind of pain she's having? We can actually use a local agent on her because she has her tumor site and she has neuropathic pain distal to it. So putting on a lidocaine patch can be really helpful. Another thing that was really helpful was we are fortunate that as part of the Palliative team, we don't just have medical providers, but there is an art therapist on our team who is a trained and licensed counselor, and got out a history from her that she didn't tell me about an assault that she was a victim to and how she has PTSD symptoms. So while I did all these medical things, a huge part of treating her pain has been the work she's done with art therapy, with psychology, with child life. She really has enjoyed breathing exercises and meditation, and she told me once that it was like rewiring her brain, which I thought was just amazing because it's true. The way you perceive pain has a lot to do with things that aren't just the signals going into your head. So she's done really well, weaning oxycodone now. Yeah. All right. So here's another case. Andy is a 14-year-old with leukemia, been through 2 bone marrow transplants. He has leukemic fevers with rigors pretty much daily, despite being on scheduled Tylenol. He also has bone pain, which has been helped by IV morphine while in the hospital. He and his family together decide to focus on comfort, and they enroll in hospice care and are discharged home. So I know this isn't really everyone's wheelhouse, but they've been on IV morphine. I didn't give you numbers again. We already did that. If they're going home with hospice, we can probably just give them oral morphine. But he continues to have discomfort because of his frequent fevers. So what do you guys think we should do now? He has leukemia. His platelets are low, but he is focusing on comfort. He's uncomfortable because of fevers, and Tylenol isn't working. Yeah. So NSAIDs are something we don't use in leukemia patients because of platelet inhibition. But understanding that's the reason why, and that's a discussion that can be had with him and his family. I would say that not all NSAIDs are created equally. So trilosate, choline magnesium trisulfate, is an NSAID which is the lowest on the platelet inhibition scale from if you had to rank NSAIDs. And it's a reasonable thing to discuss and to do for him. And so in this case, we would do that. And then he's at home doing well for a while, but his pain escalates. And it seems like it's getting more difficult to control with oral morphine. Not something I would expect most people in peds to know, but really all the tools that we have for treating pain in the hospital, we have for treating pain for hospice patients out of the hospital. So we probably wouldn't poke him for an IV line to start a PCA, but we can be creative. And in the hospice world, we use things like subcutaneous lines. You just put in a butterfly needle, you have concentrated morphine or whatever else you need so that the volume isn't too great, doesn't cause localized damage. And you can do a PCA at home with a subcutaneous line without having to worry about maintaining IV access. It falls out, you poke it in somewhere else, second procedure, not a big deal. And so he has his pain better controlled at home. So my last principle for palliating pediatric pain is to be flexible, to think maybe a little bit outside the box, but also utilize the team. And that certainly is appropriate to be calling the palliative team, but also the non-medical members of the team, the psychologist, the child life specialist, art therapy, music therapy, chaplaincy, all these other sources of suffering that feed into pain and for their own right should be addressed. We don't need to pretend to be expert in all of them, but we should know that they're there. And while I think it would be appropriate to dip your toe in the water and addressing some of these other issues, or at least attending to that suffering, at a minimum, call the people who are here who really focus on treating those things. So that's all I have for you guys. What questions do you have? All right. Well, thanks a lot for your attention and for being willing to participate. Enjoy rounding.